Thank you, everyone. Today we are going to discuss role of TKI in EGFR mutation, EGFR mutated lung cancer. Today we have a distinguished panel of experts: Professor Mofazul Hossain sir, Dr. FM Kamaluddin sir, Dr. Tawfiq Hassan Firoz, Dr. Abdullah Mamun. I don't think they need any introduction. They're very famous in their treating field. And our chairperson, Professor M.A. Heiser. Without any delay, I would like to hear a few words from our chairperson and to start the program. Over to you, sir.
Thank you, Shimon. It's a very great pleasure for me to see you. This afternoon. Hopefully, we shall be discussing about EGFR mutated lung cancer, role of TKI. This is a very standing as a problem nowadays. Lots of TKI has come up in the market. We know which one is better, which one is bad. We will have to discuss these things and find it out. Hopefully, we'll be discussing this one. Thank you all very much. Start from immediately.
Thank you, sir. So this is today's case. 50 years old lady, never smoker, presented with 1 month dyspnea and chest pain. FNSC done, lung lesion, adenocarcinoma. So at first, I would like to ask the question to Dr. Abdullah Mamun. How you will proceed this case, Mamun?
Thank you, Dr. Shuman Bhai. First, I would like to congratulate our professor, our mentor, Professor ABM Abdul Heiser, to receive his honor award. Regarding to the case, 50 years old lady, non-smoker, non-small cell lung cancer, preferably adenocarcinoma. I would like to investigate her next generation sequencing by tissue block.
Mamun, let me stop you. So you haven't for the staging. So irrespectively, you want to go for the NGS.
Yeah. First,
Mamun,
first we have to done the staging for staging purpose. Should be done CT scan of the chest and CT scan of abdomen.
Okay. So then, if the patient is in your chamber, what would be your suggestions? So how you will proceed? That is our question. So whether you should go do the investigation first or NGS first, that is not very clear.
Investigation first. First CT scan chest, then CT scan abdomen, and then molecular investigation.
What about the brain MRI and bone scan?
Bone scan should be done, but we in our chamber regularly we do not perform this investigation or MRI brain. If we suspect there is any metastasis to brain or any complication of or complaint of CNS, then we prefer to MRI of brain.
Thank you, Dr. Mamun. So, Dr. Joy, what would be your investigations? How you will going to investigate this patient?
Thank you, Shuman. Good afternoon to you all. I will first do FDG PET CT scan, followed by brain MRI with contrast, and last of all, core biopsy and molecular testing.
Okay, Dr. Jet, thank you. So you want to go with core biopsy?
Yeah.
I think that the patient comes with pre-existing FNSC, so it is not very difficult to convince the patient again for core biopsy.
But for molecular testing, core biopsy is essential. So I will go for core biopsy.
Thank you, Dr. Joy. So Dr. FM Kamaluddin sir, what is your opinion?
if exactly this patient comes to me, I don't know what is the status of the patient. So I am adequately convinced that the patient is a non-small cell lung cancer adenocarcinoma, because FNAC is a gold standard to tell that is malignant. Then I will go for staging. I will discuss about the ability of the FDG PET. If cannot do, at least I will go for CT scan, chest and abdomen with contrast. And if there is any bony tenderness on pain or alkaline phosphatase is raised, then I will think of bone scan, but not at the first beginning. And regarding the brain MRI, I will not discuss at the beginning. I will wait for the first CT scan, chest and abdomen to come. If it is a early stage lesion, maybe I will not go. But if there is a advanced stage lesion, adenocarcinoma, definitely I will discuss about the brain MRI, even the patient has no symptom. So this is how I want to proceed. But if the patient agrees, it is better to go for PET-CT. Yeah.
So what about core biopsy?
Core biopsy, actually, Shuman, yes, that is required for molecular testing. But if the patient is non-metastatic, then at the beginning, we may not need the molecular testing. So we don't need to chase the patient, because as I told, that with FNAC, we don't like FNAC. Today, we should go for FNAB. But FNAC is an adequate proof to prove that it is a lung cancer. And if it is an early stage or locally advanced, which we need to treat as a non-metastatic, there is no need of molecular testing, and we can wait. At this moment, we can avoid the molecular testing.
So your plan of management is to stage out first. Then, according to stage, if it is stage 4, then if you need any molecular test, then you should go.
I will go for biopsy, and then I will go for. And the core biopsy, you look, Shimon, there is a challenge of core biopsy also. We need to understand. Sometimes it is challenging to take core biopsy from the lung. If it is a metastatic, even we can do it from the metastatic side. So that is an issue as it is already done FNAC. So we know the very location is sometimes a big challenge in our country to do core biopsy. But yes, if it is a metastatic, definitely I will go for a tissue, either it is from lung or the metastatic side, for molecular testing and planning for further treatment.
So thank you. So Professor Mofazul, sir. So here, Kamal Bhai raised two issues. Number one, staging by CT scan, CT chest, CT abdomen, etc., versus FDG PET-CT scan. What is your opinion and why?
Well, I have no doubt about the diagnosis of this patient, because the person who has given an opinion about the malignancy and cell type without being confident, he will not give this information. So the patient has a adenocarcinoma, non-small cell lung cancer of adenocarcinoma type. There is no doubt about that. Now we have to proceed to the staging workup. Well, staging workup, that again in practical situation that will vary. If you theoretically discuss, I will advise a PET scan, because the accurate staging is necessary for treatment planning. So I will definitely advise for PET scan, but if there is limitation, then I will go for a CT scan, chest and abdomen at least, and a bone scan and a brain MRI is also, if there is indication that the disease is in early stage, because if early stage disease is there and we plan for surgery or definitive radiotherapy, then we have to exclude metastasis in the bone and brain. So I will advise those two, depending upon the CT scan chest and CT scan abdomen results. About the molecular test, well, if the subsequent investigation reveal that it is stage 2, 3, or 4, then definitely I will ask at least 3 investigations: EGFR, ALK, and PDL1.
Sir, we are coming to that issue, sir, later, sir. Okay. We are coming to this. We will probably have a long discussion in these issues. If a patient with this type of scenario come to our chamber or our OPD, so according to our discussion, at least the approach should be staging out first, preferably FDG. If FDG is not available, CT scan chest, CT scan abdomen. If symptomatic bone pain, bone scan. If symptomatic, if there is a suspicion of brain metastasis, we should proceed with MRI. So that's all from this. So we advised a PET-CT scan, and this scan comes out with this report. So it is obviously stage 4 disease. You can see there are multiple lung lesions with bone metastasis. So it is a stage 4 disease. So I think everybody should proceed with the next genome sequencing because I have got this answer from this early question. And now the question is how we should proceed with this genetic mutation. So it is single gene sequencing or NGS upfront. So Dr. Mamun.
In this case, I think NGS upfront, then a single gene sequencing.
Okay, Dr. Joy.
Okay, I will go for single gene sequencing rather than NGS upfront because most of our patients are not capable enough to do next generation sequencing because it is highly costly. So I will go for only EGFR mutation. And previously, Mofazil sir said, I will go ALK and PDL1. ALK is only 5% cases positive. So I will prefer single gene sequencing, that is EGFR mutation. Thank you.
Considering the cost issues, you prefer the single gene sequencing, right? So your prime concern is cost. Okay, thank you. Okay. So Dr. FM Kamaluddin, sir.
So Shumon, I will not go for NGS upfront. Definitely, I will go for sequencing, NGS sequencing, but I will go for EGFR, ALK, because even maximum target will be covered by EGFR, but we know 5% there is an ALK. And what is the recommendation guideline is EGFR, ALK, ROS1, and PDL1. These are the first 4 recommendations as per NCCN. And in our country perspective, I go for EGFR, ALK, and PDL1, not for ROS1 because it is not available, but all these 3 are available in our country. This is number 1. Number 2, NGS is costly. Number 3, it is turnaround time is very high. So when you go for a sequencing, you wait for the result to start the treatment. So if you send a specimen, for example, money is not an issue, we want to send the patient for NGS, then it will take at least 3 weeks to 4 weeks time. So keeping a stage 4 disease, waiting for 4 weeks time sometimes is challenging. So even money is not an issue, turnaround time is also an issue. So I always prefer to go for single gene sequencing preferred by EGFR, ALK, ROS1, and PDL1 in our country. But I don't do ROS1 because it's only 1%. So I go for EGFR, ALK, and PDL1.
So thank you, Kamal bhai. So Mofazil sir.
Exactly, I fully agree with the recommendations that has been mentioned by Dr. Kamaluddin, and I already expressed my view about in the previous as an answer to the previous question when you stopped me, said that you are coming later on. Right, the standard recommendation, and in practice in many countries, even in Western countries, they recommend as per also NCCN guideline, at least 3 things: EGFR, LK, and PDL1. Even I will take my hands off from the PDL1 as explained by the previous speakers, that it is there are 2 issues about that: the cost involvement, the time that is required to get the reports, and sometimes they say after 1 month they say that we are requiring more time to confirm the reports. So by that time in stage 4 disease, it will progress further, and the patient will definitely have, when presented, has symptoms and will be having more symptoms and more damaging tissue or organ involvement. So I will at least advise those 2 tests, EGFR and LK, if possible PDL, because in this patient for PDL1 we require tissue. So that is an issue. But at least those 2 can be done by even liquid biopsy. So why not to confine those 2? And if possible, I will make a detailed discussion with the patient that this test can be done, may be helpful for future treatment. So if you agree, then we will either obtain tissue or we will not. That is a different discussion, but first time I will advise those 2 only.
Sir, beside these 2 important issues, time and price, you have raised another issue, another important issue, that is the tissue. So if you go with the single gene sequencing after this EGFR test, whatever the methods, PCR or Sanger sequencing, whatever that, if you find it negative, and the genetic analysis center says that the tissue is taken up, there is no tissue. So don't you think that the single gene sequencing in this mode, tissue is not an issue? So I think we should not, because the whole world is changing towards the NGS, particularly for this concept that the tissue is the limitation of this tissue. So what is your vision regarding this thing, sir?
Yes, this is coming up in very near future. I think that will be a standard of investigation to go for next generation sequencing. But at the moment, I think the guidelines also will not strongly recommend to go for the NGS upfront. So I think even in NCCN guideline, you can see NCCN guideline, it is EGFR and PDL1 at best, these three.
Exactly, sir.
But
very
in near future, that may be a standard of care and standard of the investigations to be done in the first setting.
Thank you, sir. So from this discussion, we can summarize that there's definitely the genetic mutation should be analyzed. A resource-strained country, when money is a concern, we should follow the single gene sequencing. That should be a better option. At first, that EGFR by the PCR. And if EGFR mutation found negative, if there is available tissue is there, so we can do this ALK test with IAC or FISH, so any kind of fix. So again, if we found negative, then we can proceed further. But beside this, we can check this PDL1 test. Let me ask this question straight away to Mofazul sir. Liquid biopsy is very popular here. So do you believe that liquid biopsy is alternative to tissue biopsy? And if you advise this liquid biopsy, what are the conditions, sir?
Actually, tissue biopsy is preferred, but in certain conditions, when tissue is not obtainable by risking the patient, and because of the general poor condition of the patient, other comorbidities, the biopsy is risky. And tissue by the liquid biopsy, we can at least go for those two. It is not comparable. Head to head, there is no comparison as yet. But in future, but liquid biopsy is in most of the cases nowadays, it is for those two tests, at least we can adopt that liquid biopsy, as it is also available in our country. So we can advise this at this moment, but it is not as definite as tissue biopsy.
Yes, sir. Dr. FM Kamaluddin, sir, liquid biopsy.
So I want to echo what Professor Mufazal said, that there cannot be a compare between apple and orange. So tissue biopsy cannot be compared with liquid biopsy. In technical limitation situation where we cannot obtain a tissue, there liquid biopsy could be an option, because you will see many publication, many paper on liquid biopsy, but you will not find a single recommendation as a first-line recommendation to do liquid biopsy. So under any condition, it cannot be a replacement of tissue biopsy. This is a very strong message I want to send to all of our colleagues, that it cannot be a replacement. It can be an alternative in compelling circumstances where we don't have a tissue. This is number one. Number two, we need to understand that whatever paper we read on liquid biopsy, we need to go deep into it, that what was the method used? Because there are so many methods that can be used for liquid biopsy, what different platform is used. So reading one article with a high sensitivity or specificity of liquid biopsy, when we are convinced and we are trying something similar in our country, we need to understand whether the lab that we are referring is doing the same thing and whether they have some real validation of the test. That is very important. So can we really trust that? That is another question. So when we are doing the tissue biopsy, there is, more standardization is available than the liquid. So this is another. And number three, there are, the false negativity report. So when it is positive, it's positive. When it's negative, it may not be negative. So there is another limitation. So keeping all these things, I again repeat, we will do it under compelling circumstances, but never as a replacement.
Yes or no?
No.
Okay. So Dr. Joy, yes or no, liquid biopsy?
No.
Mamun?
Because
No.
Okay. So Dr. Joy, you want to say a few words regarding these issues?
Because in case of liquid biopsy, there is false positive is approximately 40%. Sensitivity of liquid biopsy is around 60 to 65%. So there is a big chance for patients who are not positive, but shown to be positive.
Okay, so let us see what the NCCN guidelines are saying. So liquid biopsy should not be used in exchange of histologic tissue diagnosis. 30% false negative rate, as said by Dr. Kamal sir, that 30% false negative rate, but if a liquid biopsy comes negative, you cannot make it confirm that really it is negative. And sometimes the guidelines give us the flexibility to use this liquid biopsy. What are the conditions? If a patient is medically unfit at all, so he is not fit for core biopsy, if this is the condition when we can think about these things, but this is not an alternative to tissue biopsy. So tissue biopsy or NGS or single gene sequencing, they needed turnover time. So by this time, the patient, what you should do with this patient? The patient histopathology or liquid biopsy, whatever may send for the genetic mutation test, and what you should do with this patient right now, Dr. Mamun.
At this status, it will depends on patient's condition. If the patient's performance status, disease burden, and the physical condition of the patient. If the patient then I can rather than the wait for the report.
Okay.
If so the patient's condition is,
please, Mamun, proceed.
If the patient's condition well.
Okay, so I got your answer. If the patient's symptomatic condition is good, then you can wait. But if it is progressive disease, then you will start with some chemotherapy. So thank you, Mamun. Your network is very poor. Hopefully it will be better and we will join again. So Dr. Joy, what is your take? What is your decision regarding this patient, particularly this patient? Okay,
this is stage 4 lung carcinoma with symptomatic. That means patient has dyspnea and chest pain. So I will go for chemotherapy and wait for molecular testing report, because molecular testing report is time consuming. It needs almost 3 weeks.
Okay, Dr. Joy. So you have started chemotherapy, and after 1 cycle, EGFR mutation positive comes. What you will do?
Okay, I wait for at least 2 cycles. If chemotherapy is responsive, then I will go for chemotherapy, followed by mutation reports. If mutation positive.
Okay, I got it. Let me clear. So there is a very interesting scenario. So suppose you have started with Pimetex carboplatin and patient responded very well. So after 4 cycles or 6 cycles, there is a question of Pimetex maintenance. And by this time you got EGFR mutation positive. Whether you are going with the Pimetex maintenance or EGFR targeted TKI.
Okay, I will go for TKI.
Okay.
After 4 cycles.
Okay, so even Pimetex carboplatin combination doing great. So you want to switch with TKI. Okay, fair enough.
Okay.
Kamaluddin sir.
So, I mean, I agree with Joy that as it was a symptomatic patient, we need to start treatment. We'll start with Prem Carbo. And as you said, wonderful response. But if you look at the data of the Pacific trial, that maintenance of Pemetrexed, and if you compare the TKI, definitely we will prefer to switch to TKI, not to go for maintenance of Pemetrexed. This is number 1. Number 2, you see this type of patient, you need to keep some reserve. So when you are exhausting all your resources at the beginning and starting TKI may not be a good idea. So the recommendation is that we can switch in between or after the completion of 4 to 6 cycle, and not to go for maintenance when you have a responsive, you have a targeted mutation. Should not go for maintenance.
So thank you. I am not going to ask this question to Professor Mofazul sir. So this patient,
you missed one point. Last, go back to your previous slide. You did a previous slide. You didn't ask any comment about the empirical TKI. That is a very
okay. So let me ask this question to Professor Mofazul sir. So is there any option to start with this empirical TKI?
Actually, I will not do that. But to tell you frankly, in my private practice, about 10 years from now, there was a lady who had a big mass adenocarcinoma in the right lung. I advised her to go for radiotherapy because she was quite old, 70 years. She refused radiotherapy. So I just put her on erlotinib. And you, from the pioneer study, you can see that the Asian people, women, non-smoker, there is 62% chance of EGFR mutation. So it varies from 22 to 62%. So probably she fell into that group. And after 1 month, when she came, I didn't find anything. So these are actually just beating, what should I say? Just trying luck. So, but ideally, we should not start on empiric TKI because the things are now available even on FNAC sample. So why should I go for that?
Okay, sir, let me ask another question regarding these issues. We don't have any data regarding the EGFR prevalence or incidence rate over here in Bangladesh. So from your personal experience, what are the percentages you may think that this percentage may be positive in Bangladeshi population regarding the EGFR mutation, sir?
Right. The number one answer is that we were not carrying out this test as a routine even 4 or 5 years back. So for last 3, 4, 5 years, we are trying to make people understand that these are the useful tests. You need to do it. Cost is an issue always. That was the reason. And the technology was also not so rapidly, so clearly or easily available as it is now. So we were not carrying out those tests routinely. Those who used to go to India or Singapore, Bangkok, they used to get it done there. And we worked on based on those information. But nowadays we carry it out. I think it will not exceed 10 to 15% in our country.
Exactly, sir. Exactly, sir. That's why I raised this question, sir. Though some countries, China, Hong Kong, even Singapore, Malaysia, they have a higher rate of this EGFR mutation, high rate. But from our perspective, I did not find that more than 10 or 15% patients comes with EGFR mutation. Kamal bhai, what is your experience?
So I totally agree with Professor Mofazul saying that in my experience also, I don't get that much mutation, even what India is claiming more than 30%. Maybe what Professor Mofazul said that maybe we are not doing extensively the test, so we are not getting the real picture. And I think one more important point should be discussed here, Shumon. I see nowadays the cards of doing test because somebody is not waiting, whatever stage, they are doing a mutation test. And sometimes in non-metastatic, unfortunately, I found some few cases, it is non-metastatic, EGFR positive patient was given osimertinib or whatever it is, I mean, TKI was given. I mean, so sometimes this is very important to understand that there is a recommendation of doing molecular test, but it should not be in stage 2 or stage 3. I mean, non-metastatic till now, there is no recommendation. But when somebody are doing a test upfront, core biopsy, then advising molecular test, and if the test comes positive, straightway jumping into TKI, not considering that it was a non-metastatic case. I think this is not a big percentage, a small percentage. We are getting some patient. We should be very cautious about this thing.
Kamal bhai, you have raised a very important issues. So not only that, you were saying about the EGFR tissue test. Sometimes we are seeing that some patients after the post-operative specimen, that is the very curative setting, the post-operative specimen was sent for NGS. So I really don't know. Though the ADAURA trial shows from the adjuvant trial, you have some role of the adjuvant. We will discuss it later. But what is the role of this NGS? I really don't know. So the judicious judgment of giving test is a very important issue.
Yeah, Shuman, I think the practice is coming like breast cancer. Any tissue go for ERP or HER2. So now it is coming that any lung tissue go for molecular test. So we should be very cautious and judicious.
Exactly, Kamal bhai. So probably we have covered all this question. Though Mofazzal Hossain sir said that he has tested with one patient blindly, but it should not be the practice because if there is no mutation, that the TKI is going to give you a very detrimental effect. So without genetic mutations, we should not proceed. And here in Bangladesh, what is our experience that not more than 15% patients are getting this EGFR mutation. So we should be very cautious regarding this empirical use. So regarding these patients, this L858R mutation comes positive. What would be your first line of treatment? Dr. Mamun.
In case of EGFR21 exon mutation, the first line should be started with TKI like arlotinib. Other drugs may be effective like afatinib and zefitinib.
Mamun, what is your prescription?
Arlotinib first, because arlotinib showed the maximum overall survival benefit.
Okay, so you have got some overall survival with arlotinib. That's why you want to give this arlotinib as a first line of treatment, right, Mamun? Okay, so, Dr. Joy, what is your selection of drugs?
Okay, Shuman, I will go for first-line treatment as a third-generation TKI, that is osimertinib, rather than gefitinib or arlotinib.
Okay, a great, Joy. Can you give us the reason behind this third-generation first-line?
Because osimertinib shown better outcome, overall survival, rather than gefitinib or arlotinib. In case of L858 are positive cases.
Okay.
And also second generations TKI like dacomitinib can also a better outcome.
So you are saying that osimertinib is better, dacomitinib is better. What would be your prescription regarding these patients? So the patient has to give one drug, right?
Okay, I will go for osimertinib.
Okay, so you want to start with third generation. So Kamaluddin sir.
So Shuman, when my patient comes with the EGFR21M positive report, I am not very happy because it is a bad news under the cover of a good news. So we know that EGFR positive, when we are treating with TKI like third generation osimertinib, we had a good survival benefit. But when it is EGFR21M or L858R, so the question is whether chemotherapy is equivalent to TKI. That is also questioned in some study. And somebody challenged that maybe we can start with chemotherapy. But still, I will go for TKI because of many reasons for the compliance and also to take a chance. There is a study of dacomitinib doing better, but as you know, it is not available and it's a bit toxic. So I will go for osimertinib. And to answer your question that why third generation first, in any EGFR mutant, I go for third generation first, because if I go for gefitinib or arlotinib first, then when it progress, then I lose the chance of 40% patient because 60% will be T790M mutant. But the 40% who will not be mutant, that we cannot go for osimertinib. But if I start from osimertinib from the beginning, I take the chance of taking this, number one. Number two, we know majority, a good number of adeno fails on brain. So osimertinib has a good control on cerebral metastasis also. So that's why, I mean, after FLAURA trial, we have enough reason to start with third generation rather to start with first generation and switch to osimertinib when it progresses.
Thank you. Mohammad Hussain, sir.
Exactly. What Dr. Kamal said, I fully agree with that. I will start with osimertinib because there are two reasons. Number one is it will prevent the emergence of T790M mutation. Number two, better with osimertinib than those of the first generation TKIs. So I will choose this osimertinib.
Shuman, when we start with osimertinib on this mutation, we should discuss with the patient that even we have a targeted mutation, but unfortunately, we are not expecting equal result of other, because there is we need to explain them that in this type of mutation, the result is not like the other mutation.
So these are all data that we have right now, that the zevitinib, erlotinib, afatinib, that are first generation or second generation TKI, all are giving you a good progression-free survival, but unfortunately, they all fail to produce any better overall survival compared with chemotherapy. So LUX-Lung-3 shows, but ultimately when LUX-Lung-3 and LUX-Lung-6 compared, but they found shows any overall survival. So first line, second line with afatinib didn't show any overall survival. So after this Archer 1050, dacomitinib shows better overall survival. You could see there is a good overall survival advantage. So this is the first generation TKI. This is the first TKI, second generation, which shows a better overall survival compared with chemotherapy. So we have got the drugs that showed better overall survival. And hence come with the third generation osimertinib. After this FLAURA trial, we could see that compared with gefitinib, erlotinib, progression-free survival near about 9 months difference. So if you compare with the gefitinib, erlotinib, there is a difference 9 months with studying with osimertinib. So Dr. Mamoon, erlotinib didn't show any overall survival till date. Till date only dacomitinib shows some overall survival and osimertinib in FLAURA trial. And in LUX-Lung-3, they show some better survival with afatinib. So I asked this question to Professor Mofazul sir. You have decided to start with osimertinib, but what harms if I started with gefitinib, comes with T790 mutation, started with osimertinib, it gives us 10 months. So first 10 months progression, another 10 months with osimertinib. So getting the same time length. So why should I prefer this costly osimertinib? Though we have the generics, but costly drugs for if we want for the originator, then it is a costly issue. So why not to go with the sequential mode, sir?
Well, that is probably applicable for our, but nowadays it is recommended that the third generation osimertinib should be started as first line in the metastatic setup when with the mutations, EGFR mutations that we have discussed already. And the reasons are two, we have already explained. After these 10 months with gefitinib, you will have definitely resistance that can be overcome by osimertinib. You can sequentially go with gefitinib, then osimertinib, but the other possibility that the brain metastasis is there. So probably in the first time, if we go with the osimertinib, we can prevent that also. That can be one explanation.
Agreed, sir. Agreed, sir. I totally agreed. So my personal practice, in my personal practice, I prefer osimertinib with the same cause that the duration of the progression-free survival is not all, but quality of life.
I want to say one extra point.
Yes, sir.
With all this treatment, compared to chemotherapy, you compare LUX-Lung-3, LUX-Lung-6, no overall survival benefit except when there is exon 19 deletion. Only yes, then there is overall survival benefit. Otherwise, all exactly, PFS benefit compared to chemotherapy.
Exactly. Yes,
though no overall survival. So exactly, that point should be kept in mind.
Exactly, sir. Exactly. So we are going to raise these issues in the upcoming slides, sir. What we have discussed so far, that we can start with osimertinib, gefitinib. After that, we can switch to osimertinib when there is T790 mutation, or we can start with upfront osimertinib. But upfront osimertinib gives you a better CNS-free outcome. So that might be a major issue for selecting this third generation osimertinib as first line.
Shimon.
Yes,
which I raised earlier, that you go to previous slide. Okay, so if you are lucky, start with first generation, and if it is T790 mutation positive, then only you can go for osimertinib. But as I mentioned in my earlier discussion, percentage around 40% will not be T790 mutant. So we will lose the chance of using osimertinib. So 10 plus 10, 20 months that you are telling will not be for 100%. But if you start with osimertinib, 100% patients.
Dr. Kasturi.
So that's why, that is another reason also that it is why the recommendation is now to start with osimertinib when it is possible, when it is EGFR positive.
Thank you, Kamal bhai. That's a very important logic for selecting this third generation osimertinib. But here this picture, that little bit downs our enthusiasm for using this osimertinib. You could see that started early with a great pace, ultimately landed in the same line. So you can say that first generation TKI, after that progressive disease chemotherapy, same outcome. First generation TKI, progressive disease, T790, third generation, same outcome. Third generation osimertinib, though you have got a very long progression-free survival, but after the progression, you are landing with the same timeline. So whatever the sequence you are going to use, this first line or third line, ultimately in the overall survival, probably they're not going to play a major role. So congratulations, sir. After this, still you are favoring osimertinib or the poor regime gefitinib, sir?
This is because of the quality of life that you are offering to a patient. Chemotherapy is, the side effects of chemotherapy patients do not like. And with oral tablets, they are very happy. But the problem is with osimertinib, there is one important issue. One should be very careful about the ECG. During the first few months, you should frequently check the QT and QTC interval. If it crosses the limit, then you have to discontinue because otherwise that's going to produce arrhythmia. And I have a patient, I cannot restart it after I stopped it because of this arrhythmia she was having. And but after at least I had to wait for 2 months before I could restart the osimertinib. So the point I want to bring here is if you see the first generation EGFR TKI, then chemotherapy, then the period with chemotherapy is longer than the first generation. So the patient is having the chemo side effects. He has to tolerate this longer than the better quality of life he had with the first generation TKI. But if you go to the bottom arrow with osimertinib, third generation, then that is the longest arrow you have in this table. So the quality of life will be much better with the third generation TKI if I start as a first line. And then for few months, the patient will be receiving the chemotherapy. And the total, yes, I fully agree, the overall survival is same with TKI followed by chemo, first generation, second generation, third generation is almost same.
Okay, sir. So so again, this question that was raised by you a few minutes earlier. So would you like to select the drug based on the specific type of EGFR mutation? 19 deletion, L858R, or there are some uncommon mutations, 20 insertion is there, T790 mutation is there. So Dr. Mamun, L858R. So do you consider this mutation or you consider it as a EGFR mutation, common mutation? Mamun.
The uncommon mutation.
No, now my question is, this patient have L858R mutation. So considering this L858R mutation, so do you consider this L858R mutation before selecting this TKI?
Yes, I can consider L858 before starting the TKI.
Okay, so if it is L858R, so is there any difference for selecting these drugs? If it is 19 deletion, okay, Dr. Joy. So L858R versus deletion 19 or an uncommon mutation. So whether your prescription will be same or the different mutations, you will going to produce different prescription.
I will go for no different prescription because 19 deletion and L858R, approximately 90% of all EGFR mutations, these two types are carry so I will go for osimertinib.
Okay. So you are not very focused to see with what is the specific type mutation. If it is EGFR mutation, you are preferred for osimertinib, right?
Yeah.
Okay. Dr. FM Kamaluddin, sir.
Shimon, we discussed it that we will support the same osimertinib, but we will discuss that when there is an uncommon mutation like this, there we are expecting not a great result like the common mutation. But till now, we discussed that except documented in one study, there is no great data to show that any specific uncommon mutation, we have to go for specific selection. So still we need to go for a common drug selection, but we need to keep in mind and also discuss that based on the type of mutation, we are expecting a different type of outcome from the TKI.
Thank you. So Professor Mufajjal, sir.
Yes, I actually answered this question before it was asked. Because with afatinib in LUX-Lung 3 and LUX-Lung 6 trial, they found that the PFS are almost same, but only when there is exon 19 deletion with afatinib, the overall survival was better. So if I get exon 19 deletion, I will try to put the patient on afatinib instead of the other TKIs. Otherwise, if it is L858R, then probably third generation osimertinib or whatever we were discussing earlier, it is almost same.
So thank you, sir. Here is the slide. You can see that though there is EGFR mutation, but this specific mutation is not same. Their outcome is quite different. You could see this blue line, that is that 19 deletion, and the maroon line, it is L858. So with all these drugs, that the first generation, second generation, you could see the better outcome in deletion 19, but a poor result with L858. As said by Professor Mufajjal sir earlier, that the L858R is not a good player. And you could see that the different drugs are working differently in a specific type of mutation. When there is deletion 19, you could see that the line is quite different and you can have a very good median progression-free survival. You could see that the overall survival is 31 versus 20, LUX-Lung 3 versus 6. But in L858R, with these same drugs, you could see that the median overall survival is lesser than the chemotherapy. So after this LUX-Lung 3 and LUX-Lung 6, Mufajjal, sir, do you think that in this type of scenario, better to start with chemotherapy as because it is giving better overall survival, or L858R we should try with some TKI?
That is a question, and I think that should be very seriously taken, and we can if the patient. The other point is the TKIs are not that cheap, so sometimes even it is costlier than the chemotherapy. So if the patient after long discussion, if the patient agrees, we will go with the chemotherapy, no problem, because we couldn't prove that the TKIs give better overall survival compared to chemo earlier in different studies, except that the quality of life is a little better. So that is also a possibility. If L858R mutation is there, then I will definitely think of going for chemo rather than the TKIs.
Exactly. The main issue of raising these issues that we should see it differently, that all EGFR mutations are not going to act in the same way. They have different approach. So we should think in depth what type of mutation is there. As Kamal already said, that if L858R, that is the documented shows some better hazard ratio, but this is very investigational. We are not in a position to straightway say that in case of L858R we should start with this documented. But Kamal bhai, just information for you, documented is now available. It is marketed by Inceptor. And these are the options in the first line treatment. There's the documented, osimertinib, afatinib, all are there according to the specific mutations. So this is the same scenario, the same question asked to the great personality, Dr. Tony Mock. And after the discussion, he concludes that any TKI may benefit patients with EGFR mutation. First line osimertinib, as we have discussed, as suggested by our senior teachers, the osimertinib has the advantage of longer PFS, OS, and better CNS efficacy. So this should be used as the first line. Combination chemotherapy, there are lots of trials that is tested with combination chemotherapy with anti-angiogenesis, but produce some PFS, no overall survival. So since we have seen that even with studying with osimertinib in the very first line, the progression-free survival is only 19 months. So why not to treat with osimertinib along with some combination chemotherapy, FLAURA2, but the interim analysis is not very promising. So probably this is not going to change the practice. So till date, this is turning of decision. Now come back to our case. The patient was started with osimertinib, third generation, in the first line, and after 2 years, patient progressed. Now, this is a very tricky situation. What to do? Dr. Mamun.
I think there is a chance of re-biopsy.
Okay,
or,
so you want to do a re-biopsy. Okay, what is the indication? What is the logic behind this re-biopsy?
Re-biopsy for the to see the new mutation or transforming to another histopathology of the cancer.
Very good, Mamun. And Dr. Joy, re-biopsy, Dr. Mamun advised for re-biopsy. Do you agree or you want to treat it?
I will agree with Mamun. I will go for re-biopsy from progressive site. And in case of non-small cell lung cancer, we see a transformation of cell from small cell lung cancer, from adenocarcinoma to small cell lung cancer. There is a 5% chance of cancer transformation. So I will go for re-biopsy from progressive tissue site.
Thank you. This is a very important issue raised by Dr. Joy, that this is the transformation. This is the total cell line is transformed to non-small to small cell. So that's a very important because the whole treatment line is changed. Let me ask this question to Dr. FM Kamaluddin, sir. You can see with the acquired mutation pattern is quite different. If we start with first generation erlotinib, gevitinib, very first line, you could see starting with first generation erlotinib, gevitinib, T790 mutation most dominates 60%. But if we start with first line osimertinib, T790 mutation is not there. You could see the main player is MET amplification, HER2 amplification, and C97X mutation. So we have reached in such a condition, our patient by somehow are in this group, probably 67% unknown group or MET amplification, HER2 amplification, and re-biopsy is done as per Dr. Mamun said, Dr. Joy said. According to this, suppose this is a MET amplification, what you should do? Should you go with this combination as per this tested trial, or you should start with chemotherapy?
So Shuman, when we have nothing, we look for something. So initially we were talking about NGS and sequencing. Now we will do everything because we are looking for a new target because we missed our target, osimertinib has progression. So now we have one option to switch to chemotherapy or look for a target, like as you said, it is HER2 or MET or PIK13, whatever it is. If we find something, and then the question comes whether drugs is available, whether cost is affordable, then we can look for that. So once the patient is progressing on osimertinib, we have option to continue with osimertinib and also add with chemotherapy. Or if we find some mutation, as you said, whatever it is by HER2 or MET or PIK13 or BRAF, then anything, if we find a targetable mutation and the availability and affordability is possible, we can switch to that.
Thank you, Kamal bhai. Professor Mumfazul Hossain sir, you are in favor of first-line osimertinib. Probably you have treated a number of patients with first-line osimertinib, and I am sure you have faced this type of situation. How you used to handle this type of situation, sir? Resistant case after osimertinib. Sir, you have to unmute yourself, sir.
Hello.
Yes, sir.
Am I audible? As
yes,
you
sir.
have said in your, shown in your slides, that there are possibilities of new mutations like MET, right? If MET amplification is there, probably we can switch over to some other TKI like crizotinib, that is that is one possibility. The other possibility is to switch over to chemotherapy. A new phase 1 trial is being carried out. It is already done. It is capmatinib. A new drug is coming up. So these are also the possibilities we have to bear in mind. In future, these may be options, but at the moment, you can continue the osimertinib as well as add some kind of
chemotherapy. So what your
chemotherapy.
personal experience, treating with this patient after this osimertinib resistance, giving chemotherapy, how these patients act, sir? Because we don't have any personal experience, sir.
I have not given to many of the patients like this. After osimertinib failure, only 2-3 patients I treated. They, for the time being, for say 5 to 6 months, they were on chemotherapy and they were doing well. Finally, chemotherapy also failed and ultimately disease progressed.
Okay. So thank you, sir. So as already sir said that this MET amplification, if MET amplification is there, we can combine with this capmatinib, tepotinib, but the median progression-free survival is not very promising. So we are in a challenging situations after the osimertinib resistance. There are a few trials are ongoing. And let's see how these coming years are coming with these results. What to do with brain mets, Dr. Joy? These patients with brain mets, suppose this is a new case with brain mets, EGFR mutation, how we are going to treat?
Okay, I will go for SRS followed by osimertinib.
Okay, thank you. Mamun? Dr. Mamun?
Osimertinib.
Okay. Only osimertinib. Dr. Kamaluddin, sir?
So that depends what is the lesion's number and location. So if the number is within 3 and the location permits, recommendation is SRS, but we need to understand in our country, a very limited center can do SRS. If we cannot do SRS, we can go for whole brain radiotherapy, but there we should try to do the hippocampal sparing because we are expecting with osimertinib, with this 3rd generation TKI, a good survival. So we need to have a good quality of life. If we can spare the hippocampal sparing, then the cognitive effect will be better.
So osimertinib with radiation therapy, right?
Radiation.
Okay. Mofazul Hossain, sir?
Yes, if along with the brain metastasis, there is no systemic progression, then I will refer to either AFM Kamaluddin or Dr. Shumon for brain, taking care of the brain despite receiving osimertinib. And I will continue osimertinib if there is no systemic progression. If there is also systemic progression, probably I will not continue osimertinib. I will switch over to something else, probably chemotherapy.
Thank you, sir. Thank you, sir.
The brain radiotherapy.
Okay, sir. So this is the FLAURA trial, which shows that the osimertinib has better progression-free survival even with brain metastasis. So how to manage this toxicity? I am not going in details because we are at the end of our time schedule. Just to discuss few minutes with this new concept that is already discussed by FM Kamaluddin, sir. So will you consider adjuvant TKI in EGFR positive case? Sir, stage 2B case, Professor Mofazul Hossain, sir, stage 2B case, operated case, you have treated with 4 cycles chemotherapy. Now, would you consider if it is comes with EGFR positive, or whether you advise this EGFR mutation test for this patient?
Yes, overall disease probability rate is better with osimertinib as adjuvant after in stage 2 to 3A or even stage 1B. It was published in New England Journal of Medicine.
Yes,
you know that is there. So I will try to follow this.
So have you started this? Sir, have you started this?
No, I have not.
So Dr. FM Kamaluddin, sir.
So it is a very exciting news, but I'm not yet convinced to start with because it is not OS, it is PFS. And we know that previously there was similar trial with gefitinib, which was very good in PFS, but finally OS. So I will be waiting to see the OS data. And till now, I will go for still the old-fashioned 4-cycle adjuvant chemotherapy after surgery.
Okay. Dr. Joy, adjuvant TKI.
I'm fully agree with Kamal bhai.
So you are not in favor of this adjuvant. So Dr. Mamun?
I will consider adjuvant TKI.
You will consider. Okay. So have you started adopting this ADAURA in your routine practice? Okay. So as said by Professor Mohammed sir, this is the New England Journal publication last year, October 2020. You could see that adjuvant osimertinib shows better invasive disease-free survival. It's stage 2 to 3, and you will be amazed to hear that the hazard ratio is 0.17. So once in a decade, you could have a hazard ratio like this in a randomized control trial. So this is a very exciting paper. Definitely, this is a very exciting paper. Irrespective of all the parameters, you could see all the parameters. Osimertinib adjuvant shows better outcome. But the question is, the ADAURA trial, this is the adjuvant trial, whether we could set our endpoint with a disease-free survival as a primary endpoint, yes or no. Now we have got this type of amazing result with CTONG trial. There is hazard ratio with invasive disease survival was 0.5. But ultimately, in the long run, at 60 months, that is 5 years, they could not find any overall survival advantage. So giving a 3 years long TKI without knowing any overall survival, I think this is a matter of debate. So as our panel of experts already opined that they are not in favor of this osimertinib, except Mamun. He is a hardcore medical oncologist, I could believe. So except him, and nobody started his practice changing. But still, it is a very interesting area. Let us see the overall survival outcome. Who knows if there is a better overall survival? We have to change our practice. But till that, probably we can wait. So that's all from me. So thank you all the panel of experts for their brilliant insights. I hope all who have joined there, they got some interesting informations. So as our academic partner is Sanofi, I would like to request the representative of Sanofi to say words. You have very few minutes to say a few words. Dr. Wasit. Wasit.
So we cannot listen to you. We're not audible.
So can you hear me now?
Yep.
That's right.
Thank you, sir.
Can you hear me now?
Yes, sir.
Just one information. I had the opportunity to witness the Lifetime Achievement Award given to Dr. Tony Mock on the IPAS trial. You know that?
Yes,
were you there in that setting, in that meeting?
No,
in
no,
ESMO?
sir, no, sir.
No, he received Lifetime Achievement Award after this IPAS trial, IPAS trial that gefitinib in EGFR mutated lung cancer.
Yes, sir. He's a big guy, sir. He's a big name.
The other point is that we call these as driver mutations, isn't it? These are called driver mutation. There is a term also called passenger mutation. You know that?
We know that, sir. But if you can say a few words, probably the audience.
Actually, there are many other molecular alteration in the lung cancer, or for that matter in any other solid tumor, solid cancers. They are less essential to maintain the oncogenic phenotyping of those cancer cells. That's why they are called passenger mutation. They do not have much of role in the treatment at the present time. So in future they may be useful for treatment purpose also. But at the moment, what alterations are directly involved, such as these kind of mutations, as we have discussed, they are involved in angiogenesis, proliferation, resistance to apoptosis, and also invasion and metastasis. That's why we are naming them as driver mutation. And the less important one are called passenger mutations. Okay. So in future, they will be useful for the treatment also. Thank you.
So thank you, sir. Yes, sir. Yes, I just go to the question. So, Dr. Fatima, you have raised one question that is answered by Dr. F.M. Kamaluddin, sir. So, T790 mutation is there. So, if T790 mutation is not there, what to do? So, you could start very early with this osimertinib, because you need not to, as said by Dr. F.M. Kamaluddin, sir, but you need not to do the T790 mutation. But again, you have raised this question.
You need to mention it. I think she is confused. It is acquired mutation. We are not supposed to see it at the beginning.
Exactly.
If we start with it in time, it will happen. So there is no rationale of doing T790 at the beginning. I think she has a confusion on that. Please explain.
No, but some of us have a preset of mind that the osimertinib is only would be for T790 mutation. No.
No, it is not.
It is also applicable for deletion 19 or T718. Also, some T7 20 insertions, osimertinib is playing some roles. So if you don't have the T790 mutation, you need not to be very upset. You can upfront use this osimertinib. So you don't check this T790 mutation. Again, back to Wasif.
Thank you, Dr. Shuman, sir. So it was a great opportunity for me to see how the country-leading oncologists are managing different cases of lung cancer. So especially the non-small cell lung cancer treatment, it has a great breakthrough in the past 15 years. I mean, especially with the first generation erlotinib, gefitinib, and currently we have osimertinib. So Sanofi Oncology has always been committed to support knowledge dissemination to the betterment of cancer management in Bangladesh. And this session is just another reflection of that vision. So I'd like to thank Professor Dr. M.A. Heiser for chairing this session today. Sir, you have done a lot for Bangladesh Oncology segment, and our words can never express the true gratitude that we all possess for you. I would like to thank Dr. Afam Kamaluddin, sir, Professor Dr. M.D. Mofazzal Hussain, sir, and Dr. Mustafa Aziz Shuman, sir, Dr. M.D. Tawfiq Hassan Firoz, sir, Dr. Abdullah Al Mamun Khan, sir, for their precious share of knowledge. Especially Dr. Shuman, sir, you are an amazing moderator, I would say, and you have kept the session lively and interesting for the whole time. So looking forward to arranging many more sessions like this in future. Thanks a lot, Oncology Club Bangladesh, for giving us the opportunity to be a part of it. Wish you everyone have a great day ahead. Assalamu alaikum.
Thank you, Wasif, for your nice words. Now, words to say from our chairperson, Professor M.A. Heiser. So over to you, sir.
Thank you, Simon. I've been listening to you, all of you. One thing came into my mind as an old man, you. Waiting period during the investigations, getting the report from the genetic testing, to wait for 2 or 3 weeks. Why don't you give them some supportive treatment? Testing, like nutritional support and everything. Plus, what I said, is spiritual medicine. Support, saying that remember Allah al-Subhanahu. Ask them to go back to Mustaqim. They have been diverted from Mustaqim. I advise them to come back to the Mustaqim. I think that might help them. Anyway, we should have to calm down the brain, the mind. They need tranquility in the mind. We have to do something in this period. Okay, thank you all very much. Goodbye, everybody.
So thank you, sir. So with this last few words from M.A. Heiser, I would like to conclude this session. Thank you all for joining.
Thank you.
Thanks, sir.
Thank you, everyone.
Intercession.
Close call.
Thank you, sir.